Up next, James Cheseboro is joined by Dr. William Boden, professor of medicine at the Albany Medical College in New York. They cover optimal management of patients with stable ischemic heart disease, invasive or conservative strategy.
Welcome to ACCEL.
Thank you, Jim. Nice to be here with you.
And maybe you can tell us about the treatment of invasive versus more conservative in patients with coronary disease. Although it's stable, there are different levels of activity that are involved too that can produce symptoms.
Absolutely. So I think we have to first bear in mind what are the goals of therapy in patients with stable ischemic heart disease. I think the first goal, if you can achieve it, is to improve outcomes, that is to say, to reduce death or MI if that can be accomplished. And certainly in the ACS population, particularly STEMI patients, we know that PCI improves survival. But all of the randomized trials to date that have compared PCI in particular versus medical therapy in the contemporary era of modern medical therapy, and this I would define as in the presence of statins, inhibitors of the renin-angiotensin system, the thionopyridines, beta blockers, calcium blockers. If you double down on medical therapy and use that broadly, as is directed by our own guidelines, then it's difficult to show incremental benefit of PCI on top of the background of optimal medical therapy. The 4 trials to date that have examined outcomes in patients with stable ischemic heart disease, of course, include COURAGE, BERRY-2D, the FAME-2 trial with FFR-guided PCI, and most recently the FREEDOM trial that compared diabetic patients to receive either bypass surgery or PCI. So those are the 4 outcomes trials, all of which, as I mentioned, have used contemporary modern medical therapy. And then, of course, the second goal of treatment would be symptom relief. And as you alluded to, there are certain patients, of course, who either have more disabling symptoms of angina or who have limited exercise capacity and don't respond to medical therapy. And so in that latter case, if the goal, therefore, is symptom relief or improvement in quality of life, then I think revascularization is clearly appropriate.
And tell us about the use of PCI versus CABG. There can be a difference, and the fact that new lesions that may develop tend to be more proximal. And of course, CABG involves the revascularization more distally.
That important question was addressed clearly in the BERRY-2D trial, which again was in 2,368 diabetics with stable ischemic heart disease. And there were 2 cohorts, PCI versus medical therapy and CABG versus medical therapy. And then in the FREEDOM trial, it was a comparison of the Taxus drug-eluting stent versus bypass surgery. And we yesterday presented a paper from our pooling consortium, which is the combined effort of the PIs of the 3 federally funded studies, COURAGE, BERRY-2D, and FREEDOM, where we examined, in fact, outcomes at 5 years among patients who were treated either with optimal medical therapy, PCI, or bypass surgery. And in that diabetic subset, or in that diabetic population of over 5,000 patients, what we clearly see for the primary endpoint of death, MI, or stroke, bypass surgery, is superior to medical therapy and was superior to PCI for event reduction. And that included not only the composite of death, MI, stroke, but bypass surgery beats both OMT and PCI for the endpoint of death alone and myocardial infarction alone. So for the so-called quote-unquote hard endpoints, if you have a patient with more extensive CAD and they're diabetic, I think the preponderance of evidence to date would support the fact that if you needed to revascularize that patient, then it would appear from these data that bypass surgery is the clear winner in terms of improving outcomes.
And you have done a nice follow-up of the long-term follow-up of COURAGE patients. And in this era of, as you point out, better medical therapy, which is preventing events by controlling the risk factors, tell us about the long-term follow-up of COURAGE.
Well, thank you, Jim. And importantly, this will be published in 2 days in the New England Journal of Medicine. But the original COURAGE trial was 2,287 patients randomized to PCI plus optimal medical therapy versus OMT alone, and followed for a mean of 4.6 years. And again, as I think everyone knows, the overall outcome of that study was neutral for the endpoint of death MI, which is the primary endpoint, and all the other hard endpoints. But we also recognize the importance of trying to ascertain extended follow-up in these patients. And so we were able to perform an extended follow-up in 52% of the original trial population that comprised 1,211 patients who were followed for up to 15 years, with a mean follow-up of 11.9 years. So to my knowledge, this is the longest term follow-up in patients with stable ischemic heart disease who were followed for survival. We found at the end of the analysis there were 561 deaths. They were equally divided between the PCI and the OMT patients. There was absolutely no suggestion of any survival benefit during this extended follow-up that went, as I mentioned, up to 15 years. And so I think it simply validates and reaffirms the original trial follow-up, but now extends that to a much longer follow-up period, so that we did at the end of the 4.6-year period had a trend toward an apparent survival benefit, but that did not materialize during the long-term follow-up.
Well, that's a very nice summary. What would you advise in terms of, in the non-diabetic patient, you think there needs to be a study looking at CABG versus PCI in that type too?
I don't know that we'll probably see another big trial like that. I suspect for the non-diabetic patients, there would be similar outcomes. I don't really think that there would be any reason to think for hard outcomes that PCI would be superior to bypass surgery. And in fact, in all the studies that have looked at this, going back more than a decade even, the deeper you get into follow-up, the more the curves separate between bypass surgery and PCI, whether you're diabetic or non-diabetic. I am not of the opinion personally that another trial would elucidate this any further in terms of the non-diabetic population.
Excellent. Maybe you can give us some take-home points here that are important in our care of the patients.
So I think first and foremost, we have to remember that trials are trials, and ultimately, as physicians, as cardiologists, we have to integrate information and apply it individually to the patient at the bedside. So I think the take-home message for me is that we have three very good choices of treatment in the stable patient. We have optimal medical therapy and lifestyle intervention, we have PCI, and we have bypass surgery. Again, if the goal of treatment is to reduce events, particularly in the diabetic patient with multivessel disease, then I would say that the data to date would suggest that bypass surgery is the clear winner. However, if patients don't respond in terms of their symptoms to optimal medical therapy, then I think PCI represents certainly appropriate intervention for symptom control and improved quality of life.
Thank you very much for coming to ACCEL.
Thank you, Jim.